If I had a 15-year-old cousin who had a BMI over 40, first thing I'd want to make sure is that my family member would be appropriately screened for other medical problems, because once you carry that extra weight, there's a high risk of carrying extra medical problems. I know from my field that traditional diet, exercise, and even pharmacological therapy fails most of the time. And I would like to at least open up the discussion with both her and her family in regards to surgical options. I think the key and important thing here is that we treat the young adult together with the family, not in isolation, because it is almost a family issue. 3/4 of obese kids grow up to be obese adults, and it has a lot to do with the family situation. So surgical options would be something I would discuss. I think I would start to become worried about obesity once your BMI is over 30. And if you're a child or young adult, once you exceed your expected growth greater than 110%. And beyond the weight requirements, it's also important to keep in mind if patients have serious comorbidities, things like diabetes, high blood pressure, sleep apnea, pseudotumor cerebri, which is an indication for us in the young adult population. And these are all very amenable to surgical correction. We cure diabetes on the order of 82% of the time, no medications. Same thing with high blood pressure and sleep apnea and pseudotumor cerebri as well. So medical problems are also an indication for the surgery as well. The different treatment options available for the young adult who is obese are generally diet, exercise. There are some medications that are of use too. Unfortunately, once patients get to a certain weight, and that's generally a BMI above 40, those interventions don't work as well. And at that point, surgery is an option for patients. And there are different types of surgery available. There's a lamp band, which is a restrictive silicone device around the top of the stomach. Sleeve gastrectomy, where we convert the stomach into a long, skinny tube. And finally, the Roux-en-Y gastric bypass, where we combine some malabsorption with restriction. Well, bariatric surgery is a serious operation, and its number one risk is mortality. And you look around the country, the mortality rate is probably about 1 out of 100. One thing that we know that helps mitigate complications is surgical volume. The more you do, the better you are. We've performed over 1,000 cases at Stanford without mortality. That being said, there can be pulmonary embolus, there can be an anastomotic leak, there can be issues with bowel obstruction, and there can also be issues with vitamin deficiencies. That's actually probably most key in a lot of our patients, is that they require lifelong maintenance of vitamins, multivitamin and B12. That's particularly important for a young adult population. Weight loss surgery has been around since 1954, and it just goes to demonstrate that surgeons have tried for quite some time to figure out a surgical solution to weight loss. Originally, probably most commonly performed was the jejunal ileal bypass, no longer performed. It's a dangerous operation that can have some serious consequences to it with malabsorption. The successor to the JI bypass that's been much more effective is the Roux-en-Y gastric bypass. It's been around since 1966, first performed by Dr. Ed Mason at the University of Iowa. Since then, there's also been other procedures, the lap band, that has great popularity in Europe as well as in Australia. And it's purely restrictive. It's a band that goes around the top of the stomach, acts much like a belt. You can tighten it or loosen it as needed. There's a couple of other procedures. There's something called the duodenal switch. That's a purely malabsorptive operation, performed rarely in the United States, a little bit more commonly in Italy. And finally, there's a relatively new operation called the sleeve gastrectomy, where the stomach, which is normally about the size of a soccer ball, is converted into a long, skinny tube. And those are the main surgical options at this point. New things coming down the road include gastric pacing, as well as blockade of the vagus, to see if any of these things can induce weight loss.